not sure who's going to introduce Ariel. She's, of course, our NICU NICUS Q&A on feeding sort of expert. So we thought it was a good starting point to make her the chair of this session. Evelyn, over to you.
Thank you, Kurt. Thank you for that kind introduction and welcome everyone. It's my great pleasure to introduce Professor Ariel Salas, who's coming to us all the way from the Children's Hospital and University of Alabama in Birmingham in the US. Thank you very much for making the time. Ariel is a board certified attending neonatologist and also an associate professor in pediatrics at the University of Alabama. He has an MD, of his alma mater is the Universidad Mayor de San Andres in Bolivia, I believe. And he has got an MSPH degree from the University of Alabama. His main focus of his research is the human diet in the extremely preterm infant. He's supported by major grants and he's studying the effects of human milk diets on the body composition of those extremely preterm babies that we look after. His long-term goal is to reduce the burden of the postnatal growth faltering, which we all know has got very devastating impact long past the time the babies are in our NICU and in our care. And he looks at novel translational studies and large-scale multi-center trials of various dietary interventions to optimize the growth and ultimately also improve neurodevelopment. He is going to present to us today on studies on the early human milk fortification in those extremely preterm infants. I think a topic that is looked upon in a variety of ways, I dare say, and there is not just interdepartmental but intra-departmental variety of practice of how to go with fortification. So I'm delighted to have you here with us today, Ariel, and over to you.
Thank you. Thank you for the kind introduction and for this opportunity to share some of our experiences, because I can assure you that we struggle with very similar issues when it's about nutrition. You know, I think in general as neonatologists, we focus a lot about intensive care and we don't see nutrition be part of it sometimes, but I'm here to tell you that that's not always the case, and that maybe there is a place for a combination of the management of critical illness and nutrition along the way. I think you can see my slides now.
Yes, perfectly. Thank you.
So we should be good here. And I'm just going to start with this picture because this is what parents are thinking about. I feel like sometimes when they get admitted to the NICU, when they have their baby born extremely premature, and they're thinking about what's going to happen in the next few weeks and when they're going to be ready to go home. And I think for many of us, it's hard to visualize this outcome, right? So we have a very small infant, very sick, probably requiring a lot of support, either with mechanical ventilation or CPAP on high settings. And thinking about this outcome, you know, growing and thriving infant, fed human milk exclusively at the time of discharge seems like a pretty remote goal to have. Here to tell you is that what we do these first 2 weeks when they're this ill and when they seem to be struggling a lot with all that critical illness, what we do nutritionally might actually matter for those long-term outcomes and to deliver this outcome that the parents would like to see once they get ready to go home. So as I talk about this simple intervention, I want you to keep that in mind, that ultimately is what we want to deliver by the time of discharge. Before I get started, though, I want to briefly go over some disclosures. I think nowadays it's probably better over-disclose and then let you choose what you think could be relevant for this presentation. But I have to say that I've received some funding through federal agencies like NICHD, but also private companies like Reckitt Johnson, and also being invited by these companies to provide some conferences. And I've done some work on oral feeding as well, specifically looking at devices that could measure more objectively oral feeding in preterm infants, and that's some work that I've done through the university. So I divided this presentation in 3 sections, and it's relatively short, so I think there's going to be plenty of time for questions, and that's what I like the most of this presentation. So hopefully it won't be too much content. But I'm just going to go over the reasons why we think this is important, this issue of early human fortification. And I'll tell you how we address this issue through the trial. And finally, I'll show you what we found. Why is this important? Well, I think things have changed in recent years. We definitely feel more comfortable with this affirmation that human milk is the best source of nutrition. Remember, at some point that wasn't always the case. We thought that formula could be a reasonable alternative, and now that has changed. I think most of us will agree that breast milk is probably the best source of nutrition for an extremely preterm infant. And the challenge with that is that enteral nutrition, human milk, even at those early stages, does not meet all the nutritional requirements that the extremely preterm infant is going to have. Specifically, the concern we have is that even though you might be able to deliver the energy that you need from human milk, because the fat content kind of secures some degree of caloric intake, the protein content could be highly variable, and that's what's going to affect the protein energy ratio, and that could potentially affect the efficacy of exclusive human milk diet on growth and body composition specifically. So looking at all this combined, basically what we want to believe is that once we agree to provide donor human milk, either in the form of mom's own milk or donor milk, if we optimize the content of protein and optimize this energy ratio, so then we should expect to see an improvement in traditional anthropometric measurements, as like weight, length, and head circumference, but also in terms of body composition outcomes, because protein intake specifically seems to be very important to increase fat-free mass accretion in preterm infants. So that's what I'm going to tell you about the why. I think if you ask the dietitians, so people, experts in the field, it makes total sense to give more nutrition to preterm infants. I think the challenge is the concerns that we have with that practice. So that's what I'm going to explain you how we thought we could approach this problem, taking care of any sort of safety concerns that clinicians have on daily basis. So we know that in order to generate this evidence, we had to go with the best study design, and that's why we proposed the completion of this trial that we called Increased Milk Protein to Critical Tissue Trial, or IMPACT trial. For the trial, we wanted to work with babies less than 29 weeks, because those are, if you look at the evidence, so those are the ones that are usually underrepresented in trials. And if people get concerned about implementing some of the clinical evidence available about nutritional practices, usually the claim they make is that there's no evidence in this specific population. And to be fair, that assessment is mostly true, because if you look at all the feeding trials, all the meta-analysis that are out there about feeding practices in preterm infants, there's a significant overrepresentation of those babies that are 28 to 32 weeks in those trials, either because those were done 20 or 15 years ago, or just because people are always limiting the enrollment of these infants on those trials. So that's why we selected infants less than 29 weeks. And to look at this type of outcomes, we felt like it was very important to go with that moderate size sample. So that's how we selected 150 infants. And what we did during the trial was to randomize them to two groups. In the intervention group, we would provide a human-derived fortifier shortly after birth, by day 3, which is around the time where babies are getting their first enteral feeds. And we did that just to promote this practice of early fortification. Now, the caveat was the eventual transition of this human-derived fortifier to a bovine-derived fortifier, which occurred around day 14, which reflected our current our standard of care at that time. Because our standard of care was our control group shown here, which was no fortification during the first 2 weeks after birth, just plain either maternal or donor milk, and then fortification at day 14 with a bovine product. So that was our intervention, that was our control group, and then our outcome was assessed at 36 weeks postmenstrual age or discharge, and was focused specifically on fat-free mass accretion. We wanted to see if, given that extra protein, that extra nutrition could help us to increase fat-free mass accretion, mostly because several studies, observational studies in most cases, show that infants with higher fat-free mass accretions tend to have better neurodevelopmental outcomes and better head growth at even up to 2 years of age. So that's how we selected the primary outcome. Now, one thing that I'd like to clarify when I describe this trial is that we did not take into consideration the volumes that the infants were getting to define the timing of fortification, which I think is one of the most problematic issues currently in defining what early truly means. Most centers will go by volume. So some centers would say that they will start fortification by the time that the infant is getting 60 cc's per kilo. Some others would say that they would start that fortifier around 120 cc's per kilo. But the time when they reach those volumes could be highly variable across units. In some units that go pretty slow with feeds, 60 cc's per kilo per day could be day 10. And even though postnatal day 10, and even though those claims suggest that that particular unit promotes early fortification, if we look at postnatal age when those fortifiers are being added to the diet, that's probably not a traditional definition of early fortification. So that's why for the trial, we ignore the amount of milk that they were at the time of randomization, and we went by just postnatal age in days. Now, as I said, we thought that fat-free mass could be the best outcome, mostly because it's overall highly accurate and precise, specifically this method of air displacement plethysmography, which requires the baby to be stable for at least 2 minutes so we can do a quick scan and determine the amount of fat mass specifically, and then by subtraction calculate how much fat-free mass they have. So it's very accurate and precise, but of course we also need to all the other traditional growth outcomes like weight, circumference. The advantage of these methods, as shown here, is that yes, so if you do it right, you can get accurate weight, length, and head circumferences. And the most important advantage that I see with anthropometrics is that they can be assessed on all infants. I think most people feel very comfortable checking weights on a daily basis, even in critically ill infants. Length, there might be a bit more pushback about it, but overall, you can get a length and also head circumferences. So that's a huge advantage of traditional anthropometric measurements. Unlike this outcome of fat-free mass accretion, which requires some degree of stability, because if the infant is extremely sick or requiring significant respiratory support, which we define as anything greater than nasal cannula over 2 liters per minute, so then that's an important limitation of the method and limits our ability to assess that outcome in the sickest ones. So that was overall the idea of the study. We wanted to see changes in Z-scores. I don't know if this has happened in Australia already, but we're trying to move away from centiles into Z-scores. I think the fact that Z-scores assume negative values makes a stronger commitment for clinicians to realize that we're getting away from the mean, and probably that's not ideal. We've noticed, even in our daily practice, that by preventing the Z-scores getting more and more negative, I think it's more impactful in clinical practice. I think there's a natural aversion for all human beings. So whenever they see that the Z-score is getting more and more negative, there's a stronger need for action versus centiles. Centiles do not assume negative values. The worst centile that you can get is 1, and the magnitude of changes that can happen at the first centile in terms of Z-scores could be massive. Sometimes the centiles could be reporting a centile of 1, and the Z-score could be -3, -4, and the Z-score cannot get any lower. I guess that's what I'm trying to say. So that's one advantage that we see with Z-scores, and for those who don't remember, we're just talking about standard deviation, right? So one standard deviation, -1 standard deviation would mean that that's a -1 Z-score, and is far away from the mean. Ideally, we want infants to keep their Z-scores around 0. So if they were born at 0, they should go home with a Z-score of 0 as well. But it's expected that some of them we're going to lose some throughout the NICU stay. That seems to be important also to define what significant weight loss is. And I think this outcome is relevant for this particular trial, because one of the claims that we're making with this study design was that by giving 45 milks shortly after birth, we could prevent the decline in weight Z-scores, which is sometimes what defines the trajectory of growth postnatally. So if growth doesn't get, if weight loss is not too severe, of course, there has to be weight loss because there's redistribution water. So probably that physiologic water loss is a decline in Z-scores of 0.8. And what we want with nutrition is to make sure that we don't make that worse. We don't make the Z-scores get any lower than that range. In this example, in this figure, I'm showing that, let's say, if this infant is born with a Z-score of -0.2, so what we expect to see in the next 14 days is a decline of that Z-score, but they shouldn't go any far beyond -1.2. That would be a -1 standard deviation decline, and that's probably acceptable. But anything further than that is probably not physiologic. It's not just water loss, but maybe loss of lean mass as a result of poor nutrition. So that's why I think the outcome of changes in weight Z-scores within the first week, 2 weeks, is relevant for this particular intervention. So now that you know how we did the trial overall, I'm going to show you our results. So we approached 233 infants and ended up enrolling our 150 infants in a 2-year period. This happened throughout the critical phases of COVID. So there were a lot of challenges talking about making sure that we had a representative sample of our study population, but we did the best we could, and we think finishing the trial in 2 years was pretty remarkable with all those challenges. We enrolled 75 in each group, and out of those 75 in the intervention group, 65 survived to 36 weeks, and 63 survived 36 weeks in the control group. Now, out of those 128, not all of them were stable enough to get their body composition assessment. So that means that only 105 infants were able to be for body composition outcomes specifically. With this trial, as you can see, we did the best we could in terms of randomization, but we did find some overrepresentation of SGA infants in the intervention group, and maybe a little bit of predominance of female infants in that intervention group as well. But the rest of the characteristics, specifically birth weight, gestational age, carcinogen exposure to anti-steroids, were not different between groups. Now, something that I would like to highlight about the trial is that it was blinded, right? So parents or clinicians didn't know that infants were getting that 45 milk because the syringe was coming. It was an amber syringe. So, and it didn't have any specific label to say if it was fortified or not. It would just say that it was maternal or donor, but they wouldn't know anything else. So that's why we did it for just the first 2 weeks, because during that time, everybody knew that they were either getting the fortified milk or the unfortified milk. But for 2 weeks, once the fortifier was ordered per clinician recommendations, so then everybody would know that that baby is now getting fortified milk. I think the masking worked really well, because if you look at this feeding practices between groups, they were pretty similar. The initiation of enteral feeding occurred around the same time. The timing to achieve full feeding did not differ between groups, which is within our standard currently, because we are a group that got pretty aggressive about advancing volumes without trophics, advancing at 25 cc's per kilo per day. So they were able to reach full feeds around, full feeds defined as 120 cc's per kilo in this case, by day 8, and was similar between groups, as you can see here. And the initiation of bovine fortifier was similar between groups as well. So again, all this to say that masking worked really well in this case and made the feeding practice very similar between groups. Now, we did not have a specific measure of feeding intolerance, so we didn't count the MPO days or the hours that feeds were, or the number of episodes in which feeds were withheld. But just by knowing that they got to full feeds around the same time, that tells us that there was really no evidence that those infants randomized to the early fortification group had for more tolerance, because otherwise there would have been a delay in achieving full feeds in that group. And as you can see here, there was no difference. The other concerning aspect of the trial was to look at the need for donor milk as a supplement, as we were trying to keep up with these volumes and trying to use the fortifier, the human milk-derived fortifier. So it's good to see that that didn't affect the ratios. So the amount of maternal versus donor milk that infants were getting was pretty similar between groups throughout the first 2 weeks. Now, before I tell you about the outcome, I want to describe in a bit more detail the safety outcome, because that's the main concern, right? So everybody gets that nutrition can improve growth, but we're worried about the safety of those practices, and that's why I want to report this. So in total, out of 150 infants, only 4 of them had true stage 2 enterocolitis. And of those cases, surprisingly, none of them occurred around the time of the transition. There was this idea that maybe during that transition from the human-derived fortifier to the bovine-derived fortifier, we could start seeing an uptick of cases of NEC, but none of these 4 cases reported here occur around that time. One occurred before the transition, and the other 3 occurred several weeks after those infants were exposed to even a bovine fortifier. So it didn't occur immediately as soon as we started a fortifier. Spontaneous perforations rates were similar again. And then if you look at the overall composite outcome of NEC, SIP, or death, was pretty comparable between the 2 groups. Now, for the primary outcome, remember, this was assessed in 105 of the 128 infants that were eligible for it. And we did not find a significant difference in fat-free mass Z-scores. They are not bad. This is pretty average for an infant with born extremely preterm, but definitely no significant difference between the groups. And same limitations with no differences in fat-free mass percentage or fat mass present kilograms. When it got interesting is when we started looking at the traditional anthropometric measurements, which again were measured on infants because there were no restrictions. So critical illness did not play a role in this. So on that, we did find some significant difference between groups. There was definitely less declines on Z-scores from birth to postnatal day 14 favoring the intervention group, closer to 0. Actually, right there where we think it's the physiologic weight loss that I was talking about, the decline of no more than 0.8 units. In the control group, definitely which a bit more weight loss during those first 2 days, first 2 weeks. And then the other interesting that we found was that there was better gain velocity for length, also better, less pronounced declines in head scores from birth to 36 weeks, as shown here for length and here for head circumference. Now, there were some questions about it, right? So I said there was an overrepresentation of SGA infants. Those infants tend to struggle more to grow. So at request of a reviewer of this document, stratify analysis of removing those SGA infants from the intervention group and from both groups. So this is a comparison on AGA infants only. And as you can see here, there were definitely more evidence that there was favorable growth outcomes in the intervention group. The declines in length scores, the difference was almost half standard deviation between groups, favoring the intervention, and for both for length and head circumference. So very interesting findings. Now, in terms of the strengths of the trial, I think it's important to highlight the double-blind design, which by definition provides the highest level of evidence for causality. Now, in terms of how this works, it's hard to tell, right? I mean, even though we thought that it was just the protein content that were increasing, it could also be related to other factors, other components of human milk. And I'm not just talking the macronutrients, but also micronutrients and also non-nutrient components of milk that could have been beneficial in a way by being offered earlier. Now, our group tends to be aggressive to advanced feeds, so it makes me wonder if there will be any sort of delays on full feeding. So maybe there's more pressure to be a bit more aggressive with fortification then, because if we're seeing benefits in a population in which we advance volumes earlier and then get to full feeds by the 8th, and by then we stop TPN, so it makes you wonder what happens to those that stay on TPNs for more than 2 weeks sometimes and have very slow advancement protocols. So maybe they'll benefit even more from this practice of early fortification. It becomes more relevant also when you think about the type of diet, right? Because for us, the ratio between maternal and donor milk was close to 70%. So 70% of the entire volumes administered in the first 2 weeks were from a maternal source, and just 30% were from a donor milk source. But if you, for some reason, work in a unit where most of the diets are supplemented with donor milk, I think in that situation, there's definitely more pressure to fortify earlier, and maybe the effect could be more substantial. Something that I also like to highlight about this trial is that the proportion of neck was comparable to previous trials of early fortification, but those other trials included the infants up to 32 weeks. So now that we're reporting on exclusively infants less than 29 weeks, now it's good to see that the proportion of neck in this high-risk population is pretty similar to the one reported in more mature infants. Now, to start wrapping this up, I just want to tell you a little bit about our assessment of what happened, why we saw improvement in anthropometric measures, but not fat-free mass accretion. And to all of that had to do with this issue that is during the conduct of a clinical trial. And these are not a trial, but just I'm using these ones for reference. So by the time that you randomize infants, you really don't know what's going to happen to them. You have an idea of who are going to be high risk and who are going to be low risk infants, but at the time of randomization, everybody's in. Now, as time goes on, though, and even with or without intervention, the high-risk population is going to start decreasing because those infants are going to start developing adverse outcomes, including death. So suddenly now there's a little bit a less representation of the high-risk population, which we think that could benefit the most from this early feeding intervention. And then the low population starts getting more overrepresented. And by the time that you assess the outcome, if infants are the ones that are very sick are not going to be able to be assessed, as I said, because you need to be on less than or just no more than cannula to be assessed for body composition. So if that's the case, now the population that you're assessing at 6 weeks is very underrepresented by especially the high-risk population is underrepresented, and then the low-risk population is overrepresented, which means that the outcome is very unlikely to differ regardless of the feeding intervention. That does not happen with anthropometric measurements. Everybody gets to be assessed, but for fat-free mass, this is going to be a concern, and I think it's important to point this out because it makes you wonder if it's reasonable to have fat-free mass as the primary outcome when you know that the sickest ones are not going to be able to be assessed. So to finalize, I just want to thank my mentor who supported me through the design of this trial and most of the trials that I've done related to nutrition, while Carlo is my division chief. Funding, because this was my first federal funding grant, and it was helpful to have the support that I needed. And of course, this is not a one-person work. I was able to build my team over the past 8 years doing nutrition research, and a lot of this work was done with their help. So to finalize, I want to say that yes, it's true that human milk fortification does not increase fat-free mass accretion, but as I show you, it seems to be relevant for length and head circumference gains, and it translates in neurodevelopment, which is what we want to do next. So then maybe it's a practice that should be justified. And I have my contact information here and the citation. This paper got published in September this year in Pediatrics, and I'm happy to take your questions now. Thanks.
Thank you so much, Ariel. That was fantastic. Thank you. Such interesting data, and congratulations on finishing this trial. It sounds like despite a lot of hurdles and spanners in the work that were thrown at you, so that's fantastic. I've got a few questions on the chat here, or actually the first one is more a request. Prakash is asking whether you'd be able to share the detailed feeding protocol that you follow for the study and also the TPM prescription. Is that in the publication or in the appendix thereof?
Yes, it is in the publication. The TPM practice is not, but I can tell you briefly what it is. So we start infants on D10 trophomin, so the dextrose and amino acids at 4% for the first 24 hours. On day 2, we add lipids, but we keep the D10 trophomin. And then by day 3 or 4, we do like a formal TPM bag with everything in it, adding electrolytes and everything else.
Okay.
And they usually stay on it for 4 more days, and we stop TPN around they reach the volumes of 100 cc's per kilo.
Okay. And how many grams of lipids do you start on?
Lipids, we start at I think we start at per kilo.
Great, thank you very much. Bert has put a question in there, congratulating on your excellent presentation and also highlighting how quite likely we don't even agree on what we define as early, let alone as to when we start fortifying. And quotes the impact trial where the intervention was started at day 3. The question he has is, with that current knowledge about enteral feeding, would you recommend the earlier start and grading of enteral feeding instead of preterms, for example, at around 12 hours of age?
We're trying to, I think there are a lot of challenges with it. I think that in a way would create some dependency on donor milk, and I'm in favor of using it. We have other trials about early full feeding volumes, as you know, feeding up to 60 cc's or 60 to 80 cc's per kilo per day on day one. There's a very large trial going on in the UK right now, Feed One. It's a kind of same concept with high volumes. But you know, when we do that, we know that we're going to have to depend on donor milk to some extent. And you know, for our definition, that we did that during the first 36 hours, and even at 36 hours, we were waiting for some mom's milk. Most of it was donor. So I think 12 hours sounds ideal, but if it's gonna be maternal milk, I would say for sure that should be encouraged. But if it's gonna be donor milk, I don't think there's that much of a rush. Maybe 24 hours is probably just fine. Maybe that can give mom a little bit of time to at least try a couple of attempts to pump and produce her own milk. Yeah.
We particularly in New South Wales in Australia, we have the privilege and benefit of donor milk access. And I have to admit, we use it quite liberally and do grade up early. But again, there's varying practices. Kurt has put another question in there in regards to the SGAs, and I have a question about that as well. Kurt asked, do you think that severe SGA, as in Z-score less than -1.6 by itself, is a reason to withhold or grade enteral feeds for several days? And I was actually going to ask the other way around, seeing that when you take out the SGAs out of your study and the effect gets bigger, do you think we should be more aggressive with the SGAs to get a better effect? So that's actually, I think, the opposite question, the opposite suggestion of that. What are your thoughts on that?
That's a great question. I think I don't think there's enough evidence to feed SGA infants. I agree. It's challenging. It's physiologic to some extent, but also appearance. I feel like SGA infants, they just look sicker because, you know, they tend to look very skinny. The belly looks big. They're on CPAP, and the belly gets even discolored once we start distending some of that with that CPAP belly. So I think in general, there are more clinical challenges on feeding them, and the evidence, yes, is limited. But I agree, those are the ones that tend to go slow on the feeds. And yes, now we are trying to work on optimizing their diets for them, assuming that they're not gonna be able to meet our goals of getting to full feeds within the first week, which would be ideal, I would say. But for them, I think we have to assume that maybe it's fine for them if it takes 14 to 21 days to get to full feeds, depending on the severity of AGA. But we need to start looking at alternatives. I think for them, yes, fortifiers, maybe DHA, all the other supplements might be more important because it takes longer to reach full feeds on them. And yeah, this evidence might not apply. But as I pointed out about high risk population, right? So because they are so high risk, they might actually benefit the most. And maybe that should be the new high risk population. Not all extremely preterm infants, but just any preterm infant with IgGR history or SGA status at birth. Yeah.
Yeah, well, excellent. Yeah, very interesting. There's another question about the fat-free mass. What are normal ranges of fat-free masses in infants below 29 weeks and at 36 weeks? Is there any data out there?
That's a perfect question. Actually, we do have a data and a data set that I got to work with some groups. This is my information. We haven't published it yet, but we're able to put together a couple of groups here in the States and some groups in Europe. We combine all the body composition data. You have no idea how hard it is to share stuff early and setting up all the agreements with all these institutions, but we were able to do it. And so we have a data set with close to So 1,000 measurements of all babies less than 32 in one cohort, and the other one has close to 900. And looking at that number, and just, and we have babies as small as 24 weeks to 32 weeks in that cohort, and the average fat-free mass Z score for those infants is close to negative 1.5. And remember, that includes babies up to 32 weeks. If we look at only babies less than 28 weeks, so the average fat-free mass Z score is close to negative 2, actually. So that's the range of normality for that. And that's the publication that we'll come out with is, if you're so far off from 0, is that 0 truly the best standard? Because that standard was developed, those Z-scores were developed based on babies that are born at 36 weeks, right? So you measure them at 36 weeks, you calculate how much fat-free mass they have, and then you define normality. But, a 24-weeker that is getting to 36 weeks post-menstrual age, gosh, has overcome a lot of other barriers. So it's very hard for them to get close to that 36-week born referent when it's just when that extremely pretty infant born under such a different conditions. So I think, yeah, that's the short answer is yes, it's terrible. It's negative 1.5 to negative 2 in average.
Yeah, it's very interesting your comments as well, because we even, fat-free mass is one thing. We don't even know what is the normal growth curve for a 24-weeker when they get to 36 weeks. Like we just assume they should be growing like in utero, but I don't think we've established that properly, what the normal trajectory even is.
And that's a good question, but a good point, Evelyn. I forgot to mention this. So one of the studies is looking at growth trajectories and body compositions. Basically, we selected infants that we thought were growing normally. So we look at the target growth, and they actually hit the target. They grew exactly what they were supposed to. And even in those babies with normal growth, the fat-free mass was extremely low still, in that range of negative 1.5 to 2. So very problematic,
I'm certainly delighted to see that the head circumference were improving, but eventually, that is the brain growing, and I'm very encouraged to hear that you were going to follow up these babies as well. So we'll eventually see what their development is going to do. There's a couple more questions just to finish off here. There is a question of whether you actually measured the protein content of the human milk that was used during the trial, and if so, were they affecting the results?
Well, we not, but we collected samples. So we have a biorepository now of those samples. We collected one sample of human milk between day 7 and day 10. So when they were in the middle of the study intervention. So those samples are being stored to aliquots if anyone wants to. I try to be careful about what to do with them. I feel like if we only do macronutrients, it's going to be very limited. We're thinking about maybe looking at, non-nutritive components, looking at IgAs and HMOs and all those sort of things. So even looking at their metabolome, once they are combined and find out what was in it that made a difference. But for now, I think it's probably, at this point, it's probably better to wait a bit, because the technology is changing so rapidly that I don't want to waste those samples on something that could get obsolete relatively soon. So, but we will have some data. And those stores have been those samples have been stored. We also have stool samples. We have the microbiome changes. So we did serial collection of stool samples, and we want to see how that changed over time as well.
Yeah, very interesting.
Yeah, this is just the clinical aspect
of
it.
That would be very interesting. Excellent. I'll give you one last question to round this off, and I think it's an excellent question as a final one from Kurt, stating that the safety of the safety data on neck is very encouraging. It's very lovely to see that it doesn't seem to be affecting neck, but obviously it's also a relatively small sample for a not very common outcome. What do you think is the best way forward? More RCTs, a large database with key feeding outcomes? If you could wish for the ideal trial or follow-up or registry of this, what would it be?
Well, yeah, very good, very fair point. I think, NEC is becoming more challenging now because truly we've done our part. I feel like from the nutrition perspective, I feel like we identified a very important risk factor, which was formula feeding. And now that we're limiting the use of formula, we've seen the effect. And I think that the fact that our rates are so low nowadays is evidence that we've tried to address this problem head on. Now, that creates challenge for us researchers, right? Because as the outcome becomes more and more rare, that makes the sample size requirement much more challenging to achieve. And that was kind of discussion, well, not a discussion, but, a comment that I got from a reviewer also on another paper, and said, nowadays, and we calculated this, for a trial of this magnitude, if we want to power it for NEC, we would need 7,000 infants in the trial to be conclusive about NEC. Because the incidence now is close to 2%, especially if they get human milk diets exclusively. So I think under those circumstances, I think it's challenging. Very hard in the States. Our center, UAB, here in Birmingham, is part of the neonatal research network. And we are used to collaborate and do trials through the network, but even for those numbers, it's kind of hard to find a place for them. Plus, there are other competing trials. And I mean, not competing in the sense that they're not the same intervention, but there are so many other trials that are being done that, as we were discussing, nutrition doesn't get sort of high priority status. So I don't think infrastructure would address this. I think the best chance are, it's really the example that we have from the UK. I feel like they've been pretty effective of getting large trials, and I've seen a lot of collaborations with you guys in Australia and New Zealand. I think that's truly the future to address these things at that large scale. Plus, the healthcare system also seems to help. Just having access to more data points, and I think one thing I saw in the case that they can merge different data sets because they have different databases that they can combine somehow. So it just takes away a lot of the costs that are big limiting factors in some countries like the States. Yeah.
Absolutely. Yeah, no, I completely agree. Like it's nice to see that we are slowly start working in our silos and starting to collaborate, particularly on data as well. Excellent. Yeah. Thank you so much. That was so informative. Really enjoyed your presentation. I will hand back to Kurt, who has hopefully found his final slide.
Well, yeah, thanks so much, Ariel, for presenting, and Evelyn for sharing. I'm just going to end off with this sharing, if you can see this share of the attendance, and thank you all. There will be one more session next week in the neonatal lecture series where the Swedish and the Japanese colleagues are gonna have a discussion about how to deal with the extremely low birth weight infants, and particularly from a nursing perspective, and dealing with these little babies. So I hope you can join us again next week. Thank you, Gold. I'll sign off. Thank you all.
Thank you very much.
Thank you. Thanks.